This presentation focuses on one of the most deceptively simple findings in pediatric EEG, fast activity in the beta range. Beta activity itself is usually normal, but in children its appearance depends strongly on developmental age, behavioral state, topography, morphology, medication exposure, and whether the activity has a convincing cerebral field. The central principle throughout this presentation is that we should never interpret fast activity by frequency alone. Instead, we need to ask whether the pattern is appropriate for the child's age, state, distribution, and clinical context. This becomes especially important because several physiological patterns, artifacts, medication effects, and epileptic patterns may all occupy overlapping frequency ranges. Our goal is therefore not simply to recognize beta activity, but to distinguish genuine physiological beta from the important lookalikes. Next slide, please. Fast transients can be particularly difficult to interpret in children because very different processes may generate activity within a similar frequency range. Clinically, beta activity is generally defined as activity at 13 Hz or above, with frontal-central beta frequently appearing around 20 to 30 Hz. But that frequency range alone tells us very little. In a premature infant, apparent fast activity may actually be the fast component of a delta brush. A 13 to 15 Hz central burst during sleep may be a sleep spindle. Fast temporal activity may simply represent muscle artifact. Posterior fast activity can be a harmonic of the posterior dominant rhythm, while abrupt stereotyped fast activity may represent an epileptic phenomenon. A useful approach is to ask 6 questions. Is the pattern appropriate for the age or postmenstrual age? What is the behavioral state? What does the waveform actually look like? Where is it distributed? Is there an important clinical context, such as medication, movement, eye opening, or a skull defect? And finally, does the activity have a plausible cerebral electrical field? The key teaching point is simple. Frequency tells us the band, but context tells us the pattern. Next slide, please. Development substantially changes the meaning of fast activity. In premature infants between approximately 24 and 36 weeks postmenstrual age, fast activity in the range of about 8 to 20 Hz is frequently embedded within delta brushes. It should therefore be interpreted as part of a normal developmental grapho element rather than as independent beta activity. Around term, beta frequency energy is present, but it is usually not a visually dominant component of the background. During early infancy, particularly between approximately 2 and 6 months, a transient high beta component in the 20 to 30 Hz range may become more apparent. After about 6 months, a lower beta component around 12 to 20 Hz begins to emerge in some infants as thalamocortical networks mature. Through childhood, relative beta activity becomes progressively more prominent while the distribution shifts anteriorly. By adolescence, physiological beta increasingly resembles the adult pattern: low amplitude, relatively symmetrical, and predominantly anterior or frontal-central. An important nuance is that greater relative beta power in older children does not necessarily mean that the beta generator itself has become dramatically stronger. Part of the apparent increase reflects the developmental reduction in delta and theta activity. Next slide, please. This developmental trajectory is easier to appreciate visually. The high beta component, shown here in blue, is particularly noticeable during infancy, with important nonlinear changes during the first year and a half of life. The lower beta component, shown in green, is relatively inconspicuous early in life, but begins to emerge after approximately 6 months and becomes progressively better organized through childhood. At the same time, the topography evolves. The distribution moves from more central and posterior regions in early development toward the familiar anterior and frontal-central predominance seen in older children and adolescents. This diagram should be interpreted conceptually rather than as a quantitative amplitude growth chart. Individual EEGs vary according to state, montage, reference, medication, and many other technical and physiological factors. The practical message remains that the same frequency can have a very different meaning depending on the child's developmental stage. Next slide, please. Before trying to identify abnormal fast activity, we need a clear mental image of normal physiological beta. Typical frontal-central beta is low in amplitude, organized, and relatively band limited. In older children and adolescents, it is usually most evident anteriorly or over frontal-central regions. It is generally bilateral and reasonably symmetrical. Drowsiness commonly makes it more visible, and it may continue into early non-REM sleep. A particularly useful feature is its temporal behavior. Physiological beta tends to build gradually and attenuate gradually rather than appearing suddenly as a sharply defined event. So when evaluating a fast rhythm, look for an organized cerebral pattern occurring in a plausible spatial distribution. In other words, a true physiological rhythm should make sense both in time and in space. Next slide, please. One of the most common practical challenges is distinguishing genuine beta activity from muscle artifact. Both can appear fast, and both may be prominent over frontal or temporal electrodes. Physiological beta is relatively rhythmic and band limited. It tends to distribute across adjacent electrodes in a way that supports a cerebral field, and its amplitude changes gradually with behavioral state. Muscle artifact is different. It is usually broader in frequency, less rhythmic, and often has a fuzzy, irregular, or sharply spiky appearance. It is frequently maximal over frontopolar and temporal electrodes because of the underlying facial and temporalis muscles. Behavior provides an extremely useful test. Ask the child to relax the forehead and jaw. Observe what happens when the child stops talking, chewing, crying, or grimacing. Muscle artifact often changes immediately or disappears during relaxation and sleep. Also remember that filter settings can make EMG deceptively smooth. Therefore, never diagnose cerebral beta simply because the waveform happens to fall within the beta frequency range. Next slide. Another important lookalike is the sleep spindle, especially when fast beta activity appears around the midline or frontal-central regions. Frontal-central beta is often faster than 15 Hz and tends to build over several seconds, persist, and then gradually attenuate. It does not usually have the classic spindle-shaped amplitude envelope. A sleep spindle is typically around 11 to 16 Hz and occurs as a discrete burst during N2 sleep. Its hallmark is the waxing and waning morphology, usually with central or frontal predominance. The most useful distinction is therefore temporal organization. A spindle looks like a well-defined N2 event with a characteristic envelope. Physiological beta is usually more sustained and less sharply bounded. In children, spindle characteristics also change with age, so the developmental context remains important. Next slide, please. In premature infants, perhaps the most important developmental mimic of beta is the delta brush. The defining feature of a delta brush is that the fast activity is superimposed on a much slower, high-amplitude delta wave. The fast component commonly occupies approximately 8 to 20 Hz. This is very different from isolated beta activity, which exists independently of a large slow carrier. Delta brushes are expected maturational phenomena in premature EEGs, and their distribution changes with postmenstrual age. The key mistake to avoid is applying adult EEG criteria to a neonatal recording. If fast activity is clearly riding on a slow delta wave in an appropriately premature infant, the correct interpretation is the developmental grapho element, the delta brush, not excess beta. Next slide, please. Three superficially similar rhythms can often be separated simply by asking where they occur and how they react. Physiological anterior beta is predominantly frontal or frontal-central, usually low in amplitude, and is not tied to the posterior dominant rhythm. A posterior alpha harmonic occurs over posterior or occipital regions and may have a frequency approximately twice that of the posterior dominant rhythm. The critical clue is that it behaves like alpha. When the eyes open and the posterior dominant rhythm attenuates, the harmonic attenuates as well. Mu rhythm is different again. It is a central rhythm, most evident around C3 or C4, often with an arciform or comb-like morphology. Mu attenuates with movement or motor activation, particularly of the contralateral limb, but usually persists with eye opening. So the bedside reactivity test is very useful. Eye opening tests the posterior harmonic. Movement tests mu. Anterior beta generally behaves independently of both. Next slide, please. Breech rhythm is another source of apparently abnormal fast activity. Normally, the skull attenuates cortical electrical signals, particularly higher frequency activity. When a skull defect is present after craniotomy, trauma, or surgery, the underlying rhythms may appear considerably larger and sharper. Physiological beta is normally low amplitude and distributed bilaterally in a developmentally appropriate pattern. A breech rhythm is focal, often high amplitude, and sharply contoured. It may contain alpha and beta frequencies and can look surprisingly spiky even when no epileptiform activity is present. The most important discriminator is anatomical correlation. If unusually prominent fast activity lies directly beneath a known skull defect, while the underlying physiological organization is preserved, a breech effect should be strongly considered. Clinical history and inspection of the scalp can therefore prevent unnecessary overinterpretation. Next slide, please. Excessive beta activity should always trigger a careful medication review. Ordinary physiological beta is usually modest in amount, low in amplitude, and does not dominate the entire EEG. Medication-induced beta is often much more abundant. It may be generalized or frontal-centrally accentuated and can produce a pattern sometimes described as beta crowding. Benzodiazepines and barbiturates are classic causes. Propofol and other GABAergic sedative or anesthetic agents can also produce prominent fast activity. The temporal relationship to medication administration is crucial. If unexpectedly abundant beta appears after sedation or medication exposure, the pharmacological explanation should be considered before labeling the pattern as pathological. The source material illustrates this particularly well in a sedated 6-year-old, where abundant high-amplitude beta activity was superimposed on irregular delta activity. Next slide, please. The most clinically important distinction is between physiological or generalized beta and paroxysmal fast activity. Normal beta is typically prolonged rather than event-like. It builds gradually, attenuates gradually, and does not show stereotyped evolution or electrodecrement. There is generally no consistent behavioral seizure correlate. Paroxysmal fast activity, including generalized paroxysmal fast activity, behaves very differently. It starts abruptly, ends abruptly, and recurs in a stereotyped fashion. It has a convincing cerebral field and is often activated during sleep. Depending on the underlying epilepsy syndrome, it may accompany tonic seizures, epileptic spasms, electrodecrement, or further ictal evolution. The most important pattern recognition rule is therefore this: abrupt, event-like onset plus stereotypy plus a cerebral field should immediately raise concern for pathological fast activity, particularly if there is evolution or a clinical correlate. This is where frequency alone is particularly dangerous because physiological beta and epileptic fast activity may occupy overlapping frequency ranges. Next slide, please. This comparison matrix brings the major patterns together in one place. Physiological beta is generally low amplitude, rhythmic, organized, and frontal-central with gradual modulation. Muscle artifact is irregular, broadband, and strongly influenced by facial or jaw movement. Sleep spindles occur during N2 sleep and have a discrete waxing and waning envelope. Delta brushes occur in premature infants and consist of fast activity riding on a slow delta wave. Posterior alpha harmonics follow the posterior dominant rhythm and attenuate with eye opening. Mu rhythm is central and attenuates with movement. Breech rhythm is focal, sharply contoured, and associated with a skull defect. Medication-induced beta is usually more diffuse and abundant than physiological beta. And paroxysmal fast activity has abrupt onset and termination, stereotypy, a cerebral field, and possible ictal evolution. When several patterns appear similar at first glance, the most useful discriminators are usually morphology, topography, reactivity, state, and clinical context. Next slide, please. A standardized approach reduces interpretation errors when prominent fast activity appears. First, confirm the age, and for neonates, the postmenstrual age. Second, determine the behavioral state. Fast activity during wakefulness, drowsiness, N2 sleep, or neonatal sleep may have very different meanings. Third, inspect morphology. Is the activity rhythmic, fuzzy, spindle-shaped, brush-like, sharply contoured, or abrupt? Fourth, examine topography. Is it anterior, posterior, central, temporal, focal, or generalized? Fifth, determine whether there is a convincing cerebral field across neighboring electrodes. Sixth, assess symmetry and focality. Seventh, review medication and sedation exposure, particularly benzodiazepines, barbiturates, and propofol. Finally, look at the rest of the EEG. Are there spikes, focal or generalized slowing, electrodecrement evolution, or a clinical event? The major take-home message is that frequency alone is insufficient. Context determines whether fast activity is physiological, artifactual, medication-related, or epileptic. Next slide, please. The evidence supporting these distinctions comes from several complementary areas of pediatric EEG literature. Foundational work on normal childhood EEG describes the marked maturational changes from the neonatal period through adolescence. More recent studies have characterized separate low and high beta developmental trajectories during infancy and have emphasized the importance of separating periodic oscillations from the changing aperiodic background. Neonatal EEG literature provides the developmental framework for interpreting delta brushes and other age-specific fast components. Studies of sleep spindles demonstrate that spindle frequency, morphology, distribution, and synchrony themselves evolve throughout childhood. The accompanying beta activity atlas chapter provides practical visual distinctions among frontal-central beta, generalized beta, muscle artifact, sleep spindles, medication effects, and paroxysmal fast activity. Taken together, these sources reinforce one central principle. Normal fast activity can only be interpreted correctly when it is evaluated against age, state, morphology, topography, symmetry, medication exposure, and the remainder of the EEG. Thank you for your attention. The purpose of this teaching package has been to make fast pediatric EEG patterns easier to recognize by emphasizing the features that separate patterns that may initially look very similar. When reviewing a pediatric EEG, remember that identifying a frequency band is only the beginning. Developmental age, behavioral state, waveform morphology, spatial distribution, reactivity, medications, and cerebral field provide the information that turns observation into interpretation. This presentation is brought to you from Professor Mohammadi's Teaching Archives.